I'm Ambry Mann.
And I'm Karen Morgan.
I'm Morgan Merriman.
I'm Kristen Morrissey.
And here at the Georgia Baptist College of Nursing, as senior nursing students, we are required to do an evidence-based research project. For our evidence-based research project, we discovered that there is a need for an obesity screening tool to be implemented upon admission to a hospital or emergency department. The World Health Organization defines overweight and obesity as abnormal or excessive fat accumulation that presents risk to health. It is becoming a world epidemic, and no one has seemed to find a solid solution to alleviate the problem. When asked to come up with a research question, we thought about what impacted our patients greatly. We found that while many patients were pre-screened for fall risk, Glasgow coma, stroke, and other scales, there truly wasn't an obesity screening scale. We noted that while in the hospital, a patient who is diabetic would receive a diabetic diet and have certain dietary restrictions. However, an obese patient would not receive the same precautions. We also noted healthcare providers were not educating patients about obesity prevention during their stay. So we thought that if there was a scale or screening tool implemented by nurses upon admission, then these patients would no longer fall through the cracks, and we could help prevent obesity if on the cusp, and if already there, we could help them become healthier individuals.
To begin to incorporate this idea of implementing an obesity screening tool into practice, the first step is to create a PICO question. The PICO question we came up with is, does implementation of an obesity screen upon admission increase education on lifestyle modification for patients who have or are at risk for obesity? This question generates an opportunity for further research that can lead to better nursing education and patient outcomes to result in healthier individuals. When searching for articles regarding an obesity screening tool, we found that there were no studies done in this area. We decided to look for other studies researching the use of various scales to aid in identification of a specific issue, thus creating an opportunity for interventions and problem solving. This method pertains to our PICO question because it provides us with evidence that implementation of these types of scales results in positive outcomes for our patients due to healthcare providers being able to more easily identify a problem and intervene as necessary.
Our search criteria consisted of current, one author or nurse, English language, peer-reviewed journal, and the keywords were body mass index and interventions. The article is titled Increased Body Mass Index Interventions, a Provider Comparison Study.
We will now start the discussion portion of our project. What was the purpose of the study?
The purpose of this pilot study was to determine if healthcare providers are recognizing and implementing weight loss strategies in overweight and obese patients. By using retrospective patient data, researchers aimed to determine if a difference existed in the frequency of interventions implemented by nurse practitioners and physicians when caring for overweight patients.
How was the sample size obtained?
The study was conducted at a primary care clinic. where currently employed nurse practitioners and physicians' interventions were compared with one another. Staff consisted of 2 nurse practitioners and 6 physicians. A computerized search of the billing records was conducted, identifying all the patients that had had an annual physical exam between October 2007 and September 2008. After this list was made, the patients were grouped into one of 2 groups: those who received care from a nurse practitioner and those who received care from a physician. Participants who met this inclusion criteria were then randomly selected. The study didn't discuss further detail about the sample size selection process.
What inclusion and exclusion criteria was used in the study?
The inclusion criteria for the study was minimal. Participants were required to be between the ages of 18 to 60, with a body mass index greater than or equal to 25. There wasn't further exclusion criteria used in the study. Who from the sample actually participated or contributed data to this study?
Those who participated in the study were as follows. 76% were women, 29% had one medical condition, 20% had more than one diagnosis, and 88% had a family history of comorbidities. Comorbidities in the study were defined as hypertension, hyperlipidemia, and diabetes. The mean age of participants was 40.4 years old, with a mean body mass index of 32.6.
What methods were used to collect this data?
In order to obtain patient data, researchers received informed consent from participants to review and extract information from their medical records. Investigators collected information on patients' age, height, weight, sex, presence of comorbidities, family history of comorbidities, whether an intervention was implemented, and if they saw a nurse practitioner or a physician. Body mass indices were then calculated by one individual and cross-examined by another for accuracy to compare the difference between age and body mass indices in the 2 groups. A statistical significance value of p equals 0.05 was used. When comparing comorbidities and family history of comorbidities, Pearson's R-square was used. A limit in this study was that they only collected data at one point in time at the patient's annual exam.
How was the sample size determined?
A sample size was not predetermined in this study. Researchers conducted a search of participants who visited the clinic for their annual physical exam. The list was then separated into 2 groups, those who were seen by a nurse practitioner and those who were seen by a physician. 90 subjects from each group who met inclusion and exclusion criteria were randomly selected. Were patients randomly assigned to treatment groups?
Participants weren't randomly selected into treatment groups. This was a retrospective study that collected patients' prior medical records for data use.
What were the main findings of the study?
The study examined whether healthcare providers in the primary care setting were successfully recognizing and implementing interventions to treat overweight and obese patients. Researchers also wanted to determine how often these interventions were being implemented by nurse practitioners in comparison to physicians. The study found that in total, healthcare providers were initiating interventions for overweight patients only 34.4% of the time. There was a significant difference, p less than 0.001, in the frequency of which type of provider was implementing the interventions. Nurse practitioners were initiating the intervention 61.1% of the time, while physicians were only recognizing and implementing the treatments to patients 7.8% of the time. These findings are consistent with other studies in this area of interest. Using retrospective patient data, the study found a significant difference in which type of provider was more likely to be seen in patients with comorbidities. Patients with multiple comorbidities were p equals 0.04, more likely to see a nurse practitioner than a physician. Was there any difference in the means or any of the statistical findings?
Using a statistical significance level of p equals 0.05, there was no difference found between the group's age, p equals 0.55, BMI, p equals 0.83, or family history of comorbidities, p equals 0.267. By using Pearson's R-square, a significance difference, p equals 0.04, was found in which type of provider-patient with comorbidities saw. Patients with more than one medical diagnosis were more likely to have been seen by a nurse practitioner than a physician. Primary care providers in the clinic initiate interventions to patients 34.4% of the time, with a significant difference between the two types of providers, p equals 0.001. Nurses practitioners acknowledge and implement interventions to overweight patients 61.1% of the time, while physicians implemented interventions only 7.8% of the time.
This article was published in the Kansas Nurse Journal, which requires peer reviews. The design of the study was appropriate to the research question, and the data obtained and analysis conducted answered the question. Extraneous variables were present in this study, therefore, they were not controlled. It is not clear that the interventions were consistently delivered or that the groups were treated equally. There was no power analysis performed, so we cannot say that the sample size was large enough to detect a true difference. As stated in the article, the findings are consistent with findings from other studies, and most of the findings are credible and clinically significant.
Obesity is constantly growing health concern for patients of all ages, sex, and race. It leads to multiple comorbidities such as hyperlipidemia, hypercholesterolemia, and diabetes. This study sheds light on how imperative early prevention and disease management is for all fields of healthcare. Nurses and physicians have ample opportunities to provide education and promote healthy lifestyle choices for all of their patients, yet this is not always being done. This article presented consistent findings with similar studies. However, the methods and data collection techniques used pose many limitations to the results of this study. Data was collected using prior medical records of patients who were seen for their annual physical exam. Medical charts are a reliable and valid source of data collection. However, there was no interaction with the patients beyond the exam, and any undocumented information was simply not considered in this study.
The generalizability of the study is threatened in that it was conducted at one primary care clinic with the same group of participants. Limitations were presented at the beginning of the study. At the clinic, there were 6 physicians and only 2 advanced practice nurses. Unequal comparison groups can cause inaccurate data. Other extraneous variables were present in the study, consisting of not predetermining a sample size, not using random assignment, and not considering the different levels of education nurse practitioners and physicians receive. A future study would benefit from using a quantitative research method that controls extraneous variables and considers the limitations found in the study.
When implementing a new tool in the clinical setting, evidence-based practice should be taken into consideration first. While there is no research on an obesity screen used upon admission in hospitals, there is an abundance of positive research on other scales used, such as fall risk or Braden scale, throughout a patient's stay in the hospital. To begin implementing the findings from our research, we would first create an obesity screening tool that would be implemented into the admission process in the hospitals. When a patient gets admitted to the hospital or emergency department, part of the admission database would include the obesity screen that we create. This process would require a healthcare provider to assess the patient's risk of obesity, which would then require the healthcare provider to educate the patient about obesity and lifestyle modification. This would create opportunities for further research to be conducted in order to test the efficacy of this tool. We believe that having an obesity screening tool implemented upon admission would create consistency among healthcare providers and increase patient education to result in better patient outcomes.
The database searched to find the articles used for this study was CINAHL, CINAHL. 8 relevant articles were found. The first article found that ICU patients with higher body mass index were more likely to have pressure ulcers than those patients who had a lower body mass index. In the second article, it was found that nurses like the use of certain scales, such as the Glasgow Coma Scale, over others due to being more timely and efficient. However, sometimes false positives would be found with the use of these shorter and quicker versions. The third article found that the use of a risk assessment scale allows for more prompt identification of those patients who are at risk. The fourth article found that nurse practitioners highly value the practice of prescribing physical activity for certain patients. The fifth article found that children whose parents are obese are more likely to be overweight or obese themselves. In the sixth article, it was found that nurses tend to spend more time with patients than do physicians. The seventh article found that further nursing education is equally as important as patient education. We chose the eighth article to do an in-depth appraisal of which was discussed earlier in this presentation.
Our nursing project focused on the need for the development of an obesity screening tool. While there weren't any articles regarding a specific obesity screening tool, there were several articles that used various other types of scales, which provided the evidence that the use of the scale to identify risk factors is beneficial to patient outcomes. Because there's not any research so far regarding an obesity screening tool, further research should be conducted to support the use of this tool after it's been developed, tested for accuracy, and implemented into practice. Nurses will also need to be provided with education on how to use this tool in order to properly use this scale. After we researched various screening tools and scales, we found that evidence does support the use of them in practice. By providing consistency in care and early identification of patient problems. We believe that implementation of an obesity screening tool upon admission to the hospital will have a positive impact on patient outcomes by making healthcare providers more aware of patients who are at risk, thus providing opportunities for education on lifestyle modification.